we're going to talk about the carrier and the outpatient files. And just to sort of highlight this point, if you notice, the reason we're using green for the words carrier and outpatient is to remind you that the carrier and outpatient are Part B files. These cover Part B benefits. So when we think about the Part A, Part B stuff that we did yesterday, these are Part B services. So these have the 20% copay and so on. And so again, as with yesterday, there'll be time for questions at the end of the segment. We also have people monitoring chat. So if you have questions during this segment, enter them into chat. I've got chat up and I'll try to do my part of answering ones that I see, but we also will answer some in real time in writing, and we'll do other ones where we'll do them at the end. Oops. So the point of this segment, the thing we're going to be doing is talking about these two files and sort of the particular issues that you're going to face. There's some very important challenges to using the files correctly and partially to understand how they interact. And just as a personal story, I ended up having to withdraw early in my career a podium presentation where I misunderstood what outpatient and carrier did. And I figured out a week before my presentation that I had made some massive assumptions that were in fact exactly wrong. So I can personally tell you this is something that we encounter every time we do an analysis. And my goal is that you understand those. And so at least if you have this, you can understand and make the decision proactively upfront rather than figuring it out a week before a presentation. So we're going to talk about the services that are found in the two files, the provider types that are found, the key variables, the structure, the physical structure of the file, which will relate to your segment later on today with Sammy, and functionally how the outpatient, the carrier, and the inpatient/MedPAR files interrelate, how this all fits together to tell a story. So in my opinion, the outpatient carrier files are two of the most confusing files for users of CMS data. And the reason is because the services and how things are divided up is determined by the billing entity rather than by the care received or anything about the beneficiary. So both files are Part B. Both files contain information about non-inpatient healthcare, particularly procedures and testing. So how is it that we have two files, and how do we figure it out? And is it random? And what does it mean is really the source of much confusion. So as you may have caught yesterday with Nathan, the source of the problem is that we have two different billing forms. We have the, and I always use the old name, so I apologize. On the left, we have the HCPCS 1500, and on the right, we have the UB92, both of which have been renamed since the 90s, though the forms are largely unchanged. We have two different billing forms, both of which can be used to reimburse for Part B services. So the carrier file is the largest of the claims files. And I said I had always, and I put almost in parentheses because every time I say something definitive, there's one exception to this rule. And that is probably the only rule with CMS data, is that there's always an exception to every rule, it seems. But it's going to have the largest number of records per person in a year. So this is our biggest file. And some of the restrictions in terms of ordering and what you can get are based simply on the volume of the carrier file. The carrier file includes claims filed by non-institutional providers who are not DME providers. So now if you're like me, you're like, what? Like just like that whole thing, like it's hard to picture, like thinking about all of the providers, you know, like what does that mean? Because that's not how we think about things. So it means, for example, that physicians, nurse practitioners that submit bills for their work, so they use CPT codes to submit it. They are not an institution. They are not a hospital. They're not a hospital billing on their behalf. Will be in this file. Freestanding, non-institutionally affiliated ambulatory care centers will be in this file. And ambulances not directly owned by hospitals will be in this file. So it's sort of an odd list, right? Frequently, it will cover, not frequently, almost always, if the healthcare is covered in other claim types, there will be an element of it in the carrier file. So it's also a file that shows a whole lot of interconnectedness and complexity of how healthcare billing works. The outpatient file, on the other hand, is considerably smaller than the carrier file. And it contains bills from institutions that bill for Part A services, but this is a Part B service. So this is Part B services from institutions that bill for Part A services. Again, so this is where all of that A, B stuff that we talked about yesterday, this is why this matters, is it isn't just about copays and deductibles, but in fact, it actually will come down to where you find things and where you look for them. The outpatient file contains institutional services that are covered under Part B. Outpatient services, renal dialysis, emergency room visits that do not result in a hospitalization, diagnostic testing that happens in an institution. So again, you can see if you're tracking this, you're like, wait a minute, these are not completely unique things between these two descriptions. And the answer is that is exactly the problem, that there's plenty of stuff that can show up either place. And that's why there's confusion. And that's why we always need to take particular care when we're working with these two files. So when we think about the outpatient claims, because this is hardest, you'll notice that almost all of the claims are actually from hospitals. So these are hospitals, which do Part A, hospitalizations are Part A benefits. So these are from hospital departments that provide Part B benefits, but the hospitals themselves also are Part A provider. So the idea is that we don't want to, CMS doesn't want to make a hospital use two billing forms. So everything the hospital does is on one billing form, and the Part A billing form trumps the Part B billing form. So rather than having some hospitalizations billed by Part B and some by Part A, they are reversing it, and they're saying some Part A service, some Part B services will show up on the Part A form. So majority hospitals, there are some what are called special facility or ambulatory care centers, surgeries, and these are ambulatory care centers that are owned by hospitals. So for example, down the road from my house is a freestanding outpatient clinic that is owned by the hospital system. That clinic bills the clinic services using the UB92, the Part A form. Likewise, clinic or hospital-based renal dialysis facilities will use this form. Home health agencies are so small you can't see it, and skilled nursing facilities will show up in the outpatient file on those occasions when the skilled nursing facility is billing for Part B services. So skilled nursing facility care is a Part A service, but occasionally they provide Part B care. So again, you've got to really watch this and think technically about which part of the healthcare benefit is paying for this. The outpatient carrier files are rarely used alone. And almost always we use both files. We can sometimes say, well, we know the probabilities and we know what we're going to gain, and we're going to, for various reasons, live with it. But we do have to acknowledge that if you want to be absolutely complete, you often need both files, and that will sometimes result in design changes. So for example, some facility claims will be in an outpatient file and some will be in a carrier file. And so a facility claim in this context is the cost to the institution. So for example, ambulatory care centers may be independent or they may be operated by a facility. If they're an independent ambulatory care center, they will bill in the carrier. If they're a hospital owned, they will bill in the outpatient. Likewise, hospitals may deliver ambulatory surgeries in a provider-based department of the hospital, in which case they could show either, depending on, because it's hospital, will be again in the outpatient. The outpatient file may also need to be used in combination with the MedPAR if you want to look at care, if you want to start at like outpatient care, but outpatient care that for various reasons could result in an admission. So for example, emergency room care, and we'll go through that in more detail. Some emergency room care results in an admission, in which case it will show up in the inpatient, and some results in a stay and then a discharge, in which case it will stay in the outpatient. But likewise, there's a procedure that could be a day surgery, but occasionally turns up into an inpatient. An example would be, for example, if somebody falls and has a Colles fracture, breaks their wrist, pinning that wrist is typically an outpatient procedure. But sometimes if people don't respond to anesthesia well, if there are other complications, they may stay overnight. Unplanned overnight stay will turn a day surgery into an inpatient stay. So if you want to find all of your wrist fracture pinning, and especially in the elderly, you're going to want to look to see how many people started there and ended up with an overnight stay. So those are examples. I just saw a question come up. So to see, so say a provider can be paid through both. No, and we'll get through that in just a minute. So let's just continue, and then we'll sort of go back through the questions and make sure we're clear. So looking at emergency room visits, as an example, the gray bar on the right shows total emergency room visits in thousands. So basically, this is how many emergency room visits. So it's 1.2 thousand. I've got to do the math. We probably should not have a data person do this because I can't do thousands in my head. But we can see that of those, about 2/3 are outpatients. So 2/3 of the people who show up in the emergency room are sent home from the discharge from the emergency room to home, but about 1/3 are admitted. So which is an interesting statistic in itself, but what it means is that if I were to only look for emergency room care in the inpatient file, I would miss 2/3 of it. I would miss the majority of emergency room care. But likewise, if I were to only look in the outpatient file saying emergency room is an outpatient benefit, I would miss 1/3, and I would likely miss a bias. The bias would be in either side, but looking only in the outpatient would mean I would miss the most severe cases because those are the cases who are then admitted. So without looking in both the inpatient and the outpatient file, I would not get a complete picture of emergency room care for the elderly. So to make things worse, and this is related to the question, the same event will often contain multiple bills. So let's just imagine a simple emergency room visit. Somebody falls, they get hurt, they're taken by ambulance to the hospital, they are seen in the emergency room, they have a hip X-ray, or they hit their head and they get an MRI of their skull and are sent home. Takes about 4 hours. I don't even want to guess the size of the bill. You can get that with the econ section later on today. I would expect a minimum of 4 claims, 4 distinct records. There will be the emergency room facility claim and the outpatient. The emergency room facility claim is the bed, the nurses, the admitting clerk, all of that stuff, that staff, the sutures, the physical sutures themselves, the X-ray or MRI machine, the X-ray tech will all be billed out of the facility. This is what the facility provides. I would then expect we will see a bill for the ER doc. And this is the person who sees our patient, who looks him over, takes a history, does a physical, says, oh, your hip is really sore. Let's check that hip and make sure we've got it right, and then we'll figure it out. The emergency room doc will bill 99% of the time out of the Carrier file. So they bill as emergency room docs PA. The ambulance is 95% of the time going to show up in the Carrier file. Ambulances can be owned by a hospital. More often, I would argue they're sort of more like licensed by the hospital. So if you see ambulances and they've got a big sign on this with a particular hospital affiliation, even if they're owned, they're typically owned as a separate business. They bill through the Carrier rather than through the outpatient file. They're not billed as part of the hospital, even if they're affiliated. And then finally, you've got an X-ray to read. So there's going to be a radiologist bill. So the radiologist is going to come in, they're going to read the X-ray, and they're going to bill for their time reading the X-ray. So you understand, for example, as a radiologist, we've got the radiologist reading the X-ray, which is billed in the Carrier. We've got the technical equipment for that X-ray, the machine, the tech, the software that is billed under the outpatient. So this is how something simple, 4 hours worth of work, thousands of dollars worth of at least submitted charges, will show up in 4 different parts. And if you only look in one file, you would find pieces of it, but you would also miss major pieces. So as we keep saying, the distinctions between the outpatient and Carrier files are confusing. They both can contain facility charges for encounters. They both can contain physician charges for encounters. But most frequently, the physician charges are in the Carrier file and either the Carrier or the outpatient, and that really does depend a little bit on market, a little bit on type of service. Either of those 2 files will contain facility charges, depending on what the facility is. So that is why we have our shorthand, we have our bets, and I will say, just as you start to understand where things are done, one of the things that I've found to be super helpful is to sort of have expectations. So I can say, well, I expect this is most likely going to happen. So cataract excisions are almost always showing up in the carrier file only. Very rarely will they show up in an outpatient file. So if I'm doing work on cataracts and I see more outpatient than carrier, I'm going to worry because that doesn't match what I understand about cataracts. But if I look at something else like, other services, we might say, well, no, that sounds like an emergency room thing, and I expect to see outpatient facility charges, not carrier facility charges. So definitely take the time to think about it and have expectations. And if you don't find it, it can be a sign that there's a problem with a code, that you've missed a code. Honestly, with ICD-10, one of the things that's super challenging is that it's easy to miss something in sequence because they're not as visually easy to look at least in my mind. Or it could be that your understanding of the benefits and who does what is off. But either way, having sort of thinking through it, doing the work, and then doing that thought exercise of saying, does this match my expectations, becomes important and will help you catch problems early in the process and make sure that your understanding is in line. So with that, let's just start with a quick poll and a check to make sure we're all together. Why are the carrier and outpatient data in separate files? Okay, I'll give it just another couple of seconds. Okay, I'm going to end the poll now. Last chance. So this is a tricky question. So first of all, the real reason, the functional reason that they are in different files is actually the third answer. They use different billing forms. If they used the same billing forms, they would be in the same file. There would be no required reason to split them up. We could split them up for other reasons, but it would be more of an organizational split than anything else. Because again, these are all Part B services, so they could easily be in the same file, but for the fact that they use different billing forms that contain different data elements. So the third answer is the correct one. You could then say, well, why do they use different billing forms? And that would make the first and second, because the services take place in different settings. And by settings here, we mean organizations that do and do not provide Part A covered services. And the organizations that provide Part A covered services are different than the organizations that provide Part B covered services only. So this is a tricky one, but just remember that when you look at those forms, the organization of the elements and the specific elements themselves do not perfectly or even easily overlap. And that is the reason they're in two, that is the functional reason that they're in two different files. So this is just, again, to remember that. So when you're looking for elements and you're crosswalking and saying, well, here's the thing I want from the carrier file, what is its equivalent in the outpatient? There will not always be a clear equivalent because they use different forms and the forms contain different elements. So with that, let's continue on. Screen to work again. So again, why, as a repeat, and we're going to keep saying this because this is a really key idea, and it's sort of, again, as we said yesterday, if you remember, we said these data are not collected for research, they're not collected for scientific inquiry, they're collected from managing an insurance company. And this is one of those where you're like, yeah, that's the only reason you would do it. If you were designing a study of sort of different types of providers and anything about them, you would never do it this way. But it is which file they show up and is entirely dependent on one thing and one thing only, which is which form they use. And the outpatient file uses the UB04, and the only entities that use the UB04 are entities that also have Part A covered services. Carrier file is populated with CMS 1500, and that is because they do not provide Part A covered services. And so therefore they do not use the Part A form. So now let's just look at the questions. Okay, so I thought you said if the services are part of the facility, then the provider bill would be in the outpatient file. So what it is the facility, CMS would consider each part, if each part is a separate entity, each part can bill separately. So physicians, so often what will happen is there will be a hospital or a hospital group, and there will be a physician practice, and the hospital group will contract or give admitting privileges to a physician group. But the physician will work for the physician group, and the hospital will bill on behalf of the hospital. So that, if you think about it, that's the reason you would get two bills, is because the physician group or groups. And the reason you would typically see each physician billing separately is, for example, there would be Alachua County radiologist PA, and that would be the radiologists who read the x-rays, and it would be Alachua County emergency room physicians PA, or North Central Florida emergency room physicians PA, and that would be the emergency room physicians who staff all of the emergency rooms. And then you might have North Central Florida ambulance service, and that would be the ambulance company. And then you would have the hospital itself. So that's how they all fit together. It's a crazy system. And I think for those, if you've ever had a procedure or had anybody in your family who's gone to the emergency room or had a procedure, you sort of realize like the bills keep coming. You know, you get the hospital bill and you're like, oh, that was disgusting and ouch. And then you get another one and another one and another one. And I think people don't realize it, but that's really how they're paid, is in pieces like that. Why isn't the data reformatted for research use? Well, so I think that is a good question. And the answer is, to some extent, the data are reformatted for research use. But the problem is that if you try to crosswalk the data elements, it's not simply a matter of rearranging things. So if it was that both files had exactly the same elements, but in a different order, you could just put them in the same order. So for elements like diagnosis code, that would be easy. Admission date, discharge date, but even the way dates are handled on the two forms is different. And I think the way to really help to get your head around it, my advice would be take the two forms and just look at them and just like truly, I went through this exercise because I said, we have to be able to create one Part B file, because it would make it would make our projects so much easier. And we spent, Steph, do you remember how long trying to create one form? And we finally just realized that it really cannot be done without some level of rolling things up. But and we were not the first, and I know we were not the last to try to get these, but we have never been able to find a way to do it because they're just different enough that it's not just a matter of reordering, but it's in fact what exactly they contain isn't the same. If the hospital hires and pays the docs and they are not a separate group, the physician bill would be in the outpatient file. Yes, that is exactly correct. So I think the reason the hospitals typically keep the docs separate is actually related to prospective payment. So if you remember yesterday when we talked about paying, we talked about DRGs, and hospitals are paid on prospective payment, which is based on expected resource use. And then after the fact, if the actual costs are greater than the prospective costs, then there's an accounting that happens a couple years later. Well, if the prospective payment doesn't bill in physician services. If those are in the prospective payment modeling thought to be separate, an ambulance is separate, and a hospital bills, then the hospital has to cover those things out of the DRG. And while they can certainly make up for it a couple of years later during the cost report process, that accounting, it means they will actually be delaying payments they could get for up to a couple of years. And I think that's the reason the hospitals do it this way, is because it's really a way to maximize revenue by keeping the prospective payment as it was built around hospital resources and keeping things that were not part of that building, physician services and ambulances, and billing for those separately, because otherwise those have to be covered under the DRG. I don't know if that makes sense, but if I were an MHA, which I'm not, that's how I would think about it. If my job was to make sure that the hospital got all of the legitimate payments they could get. So we're not talking about billing for things that weren't correct. We're not talking about overbilling. We're just talking about maximizing legitimate payment. Does that, so then there's some specific ones. So if you wanted to determine the cost of a surgery or procedure, you would have to take a subset of the population in the carrier file. So that's, in fact, we'll talk about that as we move forward. And Sammy will talk about it again later on today. What does it mean if you want to put everybody together? And then what we'll talk about at the end of the day is, so if this getting everybody together matters, how do you ask for the data to make sure you have carrier records on 100% of your patients and not just on 5% or 20%? Is that good? Any other questions? In that case, let's move on to more about the outpatient. So the outpatient file has the same structure of an institutional claim. And that is to say, it is in base plus segments. So it has a base file, one per record. It has revenue centers. Remember all the discussion of revenue centers? Well, outpatient has revenue centers as well. And remember, people can have multiple revenue centers, variable numbers. There are condition codes, occurrence codes, span codes, value codes, and demonstration codes. There are some fields that are not populated in the outpatient. So for example, and there's a word missing here, it's ICD-9, 10 procedure codes are blank on the outpatient file because HCPCS or CPT codes are used as the basis of payment. So there will not be ICD-9 procedure codes, even though there are spots on the form for them. Okay. The structure, we're going to focus on two parts of the structure. We're going to focus on the base claim and the revenue center file, but the other four segments have valuable information. And often, if you want to know why a hospital got paid what it got paid, or what were the extenuating circumstances associated with that hospitalization, those four segments can become very valuable. So they're worth digging into, particularly if you say, I want to find something, or I want to distinguish between the group of Medicare people who has private insurance and those don't, or a group who had injuries that were paid for out of some sort of auto insurance versus people who were not, or whatever. So those are very useful files, but they're very technical. So these are not, the other segments are valuable but not simple. And what they take is someone who's got a lot of patience for reading documentation and asking and digging. But I think they're also underappreciated personally. So the base claim file. So there's one record in the base file for each claim. Okay, so if somebody has 14 outpatient claims in a calendar year, they have 14 base claim file records. The base claim file is going to contain the demographic information, date of birth, sex, race, so that you could ask, why do I need to get it from the MBSF, as I argued yesterday, when we have it right there? And the answer would partially be depending on what your design is, which one makes the most sense. There will be summary information about the claim. There will be total claim payment amount, There'll be the diagnosis codes, ICD-9 and ICD-10. There'll be provider IDs. There'll be claim start and end dates, and there'll be a type of facility code. There is no, at least right now, information about the individual services provided in that base claim. So you can say, I know where they were, I know when they were, I know why they were, right? But I have no idea what happened when they got there. So that sort of would be my summary of the base claim. So if you remember, we've got the Medicare provider number. We've talked about these. Just remember the Medicare provider number, for example, is a 6-digit number. Digits 1 and 2 are state. Digits 3 to 6 cover facility type. It's always populated, and it can be used to link to the provider of services file if you want to know more about the provider. There's also an organization NPI. There are very few of these that are missing. They're almost always present. It contains no embedded information, but it's linked to the NPI number. So again, some of what you can do is sometimes we'll say it's just a, what is it, an intelligence-free identifier like the NPI, or it's an intelligence embedded number such as the provider number. There are claim from and claim through dates. For most outpatient records, these will be the same because again, a lot of these are outpatient services, so people will come in and leave on the same day, same calendar day. A small percentage of claims, about just over 10% in 2019, will have different claim from and claim through dates. And these are typically one of 3 things. Emergency room visits that go past midnight. Somebody comes in on Thursday at 10 p.m., is discharged Friday morning at 6 a.m. Their admission and discharge dates will be different. Observation stays. And observation stays, as you may know, are when somebody shows up at the emergency room and the emergency room staff is trying to decide whether the condition is serious enough to justify an inpatient admission. So they're sort of in this limbo of, we don't think they're healthy enough to send home, but we're not sure they're sick enough to be admitted. They will often stay in what's called an observation stay. Observation stays will almost always be more than 1 calendar day. And then there will be some services, radiation treatments are the most common, that are billed on a monthly basis rather than a daily basis. So if somebody is getting radiation for a breast cancer, for example, and they get rated 5 days a week for 6 weeks, rather than billing that as 30 different bills, for the radiation treatment, it would typically be billed either weekly. So there might be 6 bills each for a week, or there might be 2 bills for the 6 weeks, 1 after 1 month and 1 for the remainder. So those are reasons why the claim from and claim through dates would be different. So again, those are unusual. But again, if you look at this and you say, well, why would this happen? And why would this have a different admission and discharge date? It should make sense. So that's the other piece where, again, as Steph talked about, checking your algorithm and looking at a few claims that don't meet your expectation. That's what it is. Now I've got a question, which is, what is a claim through date? So a claim through date is the claim what I am billing for starts on date whatever and ends on date whatever. So if it's a single day and it is today, I should know this, today is June 23rd. It will be the claim from date is June 23rd, and all the charges are through June 23rd. So that's saying that those are the limits for which the charges apply, 1 calendar day. Alternatively, if it was something like radiation, we could say the claim from date would be June 1st, 2023, and the claim through date would be June 23rd because all of the treatment is ending today. So that is what a claim through date. I get asked sort of routinely, well, why wouldn't they just make the claim through date the end of the month? Why couldn't they make the claim from and through wider than the service dates? And I think the reason is you run a risk. If you do claims, if the same institution has 2 overlapping bills, both of which are the same service dates, because you don't know what's going to happen tomorrow, there could be some question about whether that's appropriate billing or not. So I think that's the reason they tend to keep these pretty precise. So there's no question of, well, wait a minute, are you billing for the same thing twice, especially when it's something that could happen legitimately more than once. The diagnosis codes. So right now, ICD-10, as we've said, starting in October 2015, as I have to figure, and just this is the only outpatient segment that contains the diagnosis codes. So the base file has the diagnosis codes. If you want to know what was wrong, you have to do it there. Beginning in 2010, with everything else, we talked about the number of diagnosis codes in the file, expanded from 10 to 25. And the mechanism of injury code, which we talked about yesterday, is moved to a separate, quote, E-code field. So just remember, so those, if you're going way back, which is becoming less and less of an issue, just those were key dates for change. And then the principal diagnosis code is an exact duplicate of DX1. So if you're writing an algorithm and you do a crosstabs to compare principal diagnosis and DX1, you should not find any mismatches. And then just remember that rule out diagnoses will sometimes be present on a claim. And this is sort of this challenge with, and I wouldn't say it's overcoding, it's sort of coding what might be happening. So why did we do, so the question is, what diagnosis do you do to explain why you x-rayed that hip? You didn't, if the x-ray comes up negative, you can't put totally normal hip, right? Because that will never be. So what ends up happening, I believe, is that in some cases they put what they think it's going to be or what they're worried it might be, and rather than what exactly it ends up being. And this is common in outpatient and carrier alike. And you could also argue in some cases a diagnostic journey is started in this day, but we may not get the test results. And so something has to be put there. And so that's why rule out diagnoses would show up as well. I would just see, we've got a question. Oh, Stephanie answered it. Payment fields, and we'll talk about these payment, oops, excuse me. We'll talk about, I am messing up, talk about the payments later in terms of how to interpret it. But just as a brief thing, the total amount Medicare paid for the claim will be called the claim payment amount. The total amount already paid by another insurer is the primary payer claim amount. So Medicare primary payer is a payer other than Medicare. So it's private insurance. So the primary payer is not the first payer, it's the non-Medicare payer. So I think that language is often confusing to people. And then Medicare will actually decide what is due from the beneficiary. The beneficiary, of course, could have a Medigap policy, so it's no guarantee that the beneficiary themselves will actually pay for it. But it will be the Part B deductible amount. Remember that annual deductible we talked about? It will be the co-insurance amount. That's that 20% co-insurance. And then there's a blood deductible liability. So technically, when somebody receives blood products, there's a separate copay there. That one is not, as for sort of obvious reasons, is not as obvious, is often seen, and people will often forget to include it or decide it doesn't matter. But just to be complete, the blood deductible is there as well. And so if you're a person who cares about understanding why somebody is paid and wants to go deep into the incentives, you might want to make sure you don't miss that one as well. Denied claims, and this was a question that came up, which is what happens if a claim isn't paid? There'll be a claim payment amount of 0, not paid, and about 3% were completely denied. And the most common denial code is N, which is not paid, or all other reasons for non-payment. So we actually there was a question earlier in the chat, if you missed it, it's like, can we tell why? And we thought that when we spent some time looking into that, oh, that'll be really interesting. We might understand what people are doing and why they're doing. And the reality is it's rarely completed in a way so we've had to come up with other algorithms that explain why we think it's likely to be not paid. Personally, I think the most common reason for non-payment is just inadvertent duplicate billing. You know, these are all electronic, and if you think about just sort of hitting, it's like we always get warned when purchasing, especially airline tickets, like do not hit submit again, or you're going to end up with a whole, with a whole pile of tickets. Well, the same thing happens with claim submission. And if it seems like the computer froze and you hit submit again. In some cases, you'll end up with two bills. One of them will be denied and one will be accepted. So when looking at denied claims, it's going to be important that you spend some time yourself and not just counting in these codes to make sure you understand the basis of denial, because otherwise you could end up quite confused. Like, I don't know why this wasn't denied, why this was denied. It looks completely reasonable, when in fact the duplicate billing is the best explanation. So the revenue center file. So what are revenue centers? Revenue centers are revenue generating divisions within a file, within a provider. So in fact, I looked this up yesterday, and CMS in one of their other websites says, let me just pull it up. The provider assigned revenue code for each cost center for which a separate charge is billed. Okay. These are revenue center files. And so this is how billing happens in this file. So they're 4-digit codes. These are copyrighted codes. So one of the things you will see is you will have to sign a copyright acceptance thing. And the ResDAC website they monitor it regularly about whether or not we're violating copyright. So do know we will send you to the AMA for that. These are generally used for internal record keeping by the hospital. They do not impact payment. So although they're used and there's a common structure, there is nothing in the payment, like for example, in the outpatient file that says, well, we're going to pay it differently, with just very few exceptions, if you call something a general emergency room versus a medical emergency room. There clearly are some, for example, observation units where the billing is very specific, but there's a whole lot more opportunity in terms of possible revenue centers that there's no reason. You could general radiology versus X-ray, for example. So to be clear, institutions are not required to use all possible revenue centers. So it's really important to not overinterpret the presence or absence of revenue centers if you're trying to understand whether a facility has certain types of care. And so just so you can see this as an example, there are 9 possible emergency room revenue centers. So 0450 through 0459 are all emergency room revenue centers. Emergency room payments do not depend on which one it is. There also can be very specific codes, such as 0307, which is urology lab, or there could be a very general laboratory. You could have very specific pediatric clinic, 0515, or you could have a more general outpatient clinic. The payment for those will not depend on whether you use the most specific or the most general. Oops. So in the revenue center file, each claim will have at least 2 records in the revenue center segment, or what I sometimes in old language you'll hear the revenue center trailer. One of these records is a summary record, and that will have a revenue center code of 0001. It's a summary record. It summarizes everything else. So it will have the sum of the charges and sum of payments, and it should be, and those should all equal up. The big thing is, be sure to investigate the record containing 0001 because it may contain duplicate information. The reason we say may is we've talked a bit about the limited data sets, which ResDAC does not support, and the research identifiable files. The revenue center file is built a little differently in the limited data set. So without getting into too much detail, you need to watch the use of the summary record. In general, we exclude it. It just summarizes things. And so to avoid double counting or anything else, we just do it. We just get rid of that record typically, or use it as a check of our own math. Just reminding you that HCPCS are the basis for Part B services. Level 1 HCPCS are also called CPT codes, current procedural terminology. They're a 5-digit code. They begin with a number. They're published by the AMA. They're copyrighted. Code books must be purchased. We've sometimes gotten through eBay. It used to be we'd get old paper code books because everyone got them. Now I think everything is digital, but you're going to want to make sure you actually have access to a code book and not just counting on somebody's posting of what are the codes you should use. I really encourage you to have the ability to look at the codes yourself and decide yourself whether you agree with the coding that everybody else has done. So sometimes you'll see in articles, we use CPT codes. Sometimes you'll say we use HCPCS. And the reason is CPT codes are HCPCS. Okay. The other piece is, then we have what are called level 2 HCPCS. And these are billed for things that aren't CPT codes. So this, if you think about it, the AMA publishes level 1. These are things that docs do. Level 2 are things that you still need to bill for. They're legitimate things under Part B, but they are not things that doctors do. Or they are things where CMS has decided to make a separate code to make it easier to monitor policy. So that's what the level 2 are. They're two different things slammed together. So for example, it could be used for chemotherapy agents. So the AMA doesn't publish the agents, but if someone is getting chemotherapy in a hospital chemo unit, we need to bill for the agents themselves. And those would be billed using a HCPCS, a special CMS code. But likewise, CMS decided at one point, as Nate showed you an example, to create a special screening mammography code so that they, for a matter of policy, could monitor and manage screening mammography and handle the co-payments. The level 2 code books are free and they're available on the CMS website, and they're well documented, and they show when codes are added and when they're sunsetted. Level 3 has 5-digit codes that begin with a W, X, Y, or Z. And these are locally created when no level 1 or level 2 HCPCS exists. So if something happens and the AMA has not caught up with science or practice, and we still have a bill we need to pay, what will happen is the carriers, the people processing the bill, will often create a temporary code that can be used while the decision is being made and AMA goes through their process. Note, XX000 is a diagnosis. You'll see in the diagnosis code. It is not a HCPCS. It is not a CPT code. It is a diagnosis code for laboratory services, and it is used because laboratories are not expected to have a diagnosis code. They are doing a service. All level 3 fields, so level 1, CPT codes, level 2, HCPCS, and level 3, these temporary local codes are all stored in the field HCPCS code. There has to be one HCPCS per line in the outpatient file. When you're looking at HCPCS, just remember these are grouped by type of service, and that grouping can be very useful if you're trying to understand what happened. Anesthesia, surgery, radiology, pathology, etc. E&M, evaluation and management, is useful. Evaluation and management codes will tend to be different based on both location of care and complexity of patients. So there are different E&M codes for emergency, for new patient, for established patient. Examples of level 2 codes include ambulance services. So ambulance services are going to be an A code, so between A0000 and A0999. Different therapies will have A's, B's. A lot of chemotherapies are going to be in the J range. So again, you can look at these codes, and what they should be are things like supplies or things that are policy. And these are the G codes. So for example, the annual wellness visit is assigned a HCPCS of G0438. So yes, it is absolutely possible that we could come up with an E&M code that would match it. But because the annual wellness visit is something specific and also has specific payment and deductibles and co-payments, it is linked to a G code. Self-management training, cancer screening, initial preventive physical exam will all have separate codes for policy. You do have to watch these. This would be the big advice. And if you remember, that's the example that Nate showed yesterday, which is the policy changed, the decision about whether to monitor it changed. So this is, again, an example where you can use these codes for policy. You can use these codes to understand what happens when policy changes. But if you're just going along and trying to make sure that you pick everything up, you're going to want to look at some sort of a time trend or do other investigation to make sure the policy didn't change, and that it's not going to inadvertently affect what you're trying to do. Level 1 and level 2 HCPCS change annually and often without notice. So level 1 codes are determined by the AMA. They change annually. And in fact, we had a case a few years ago where the AMA just sunsetted all breast surgery codes and put new ones in. So I had a friend who was doing work and had done a beautiful evaluation work, figured out an algorithm, and then the codes changed and everything else, moved with it. Level 3 HCPCS change more frequently. And again, that is because these are local codes that are determined when there is a need, and we don't want to have to wait for this annual process that the AMA and CMS go through. So CMS continues to minimize the use of level 3 codes. They tend to try to encourage use of existing codes, even if they're more general, not otherwise specified. But there will always be a few of these codes, and you can sometimes figure out what they are, and you can sometimes not, depending on just what the service is and how much sort of internet traffic there is around it, or how formal of a decision has been made. Hospital is now paid on what's called the HOPS, or the Hospital Outpatient Prospective Payment System. And in this case, what happens is HCPCS are translated into ambulatory payment classification, or APCs. They're given a relative weight. There's a payment rate that comes from it, and the minimum unadjusted copayment. So again, just as we have prospective payment in the inpatient, this is an attempt to bring the same thing into the outpatient. So for example, we've got a HCPCS code, we've got an APC, which translates to a relative weight, which translates to a payment rate, which translates to a minimum unadjusted copayment. So you notice, for example, there are a number of colonoscopy codes that are all treated exactly the same. They all have a relative weight. For example, if you see in this example, there are 6 of them that have different HCPCS, but all have the same relative weight of 11.9079, which means they all have the same payment rate, which means they all have the same minimum copayment. So this is an example of how the system works. Is again, so it's a kind of a cross between the RVU model we see in the Carrier file and that people are used to, and the DRG we see in the inpatient. The other thing with the revenue center data is we have date service was rendered, which is, since most services are done on a single day, it doesn't matter. But no, there is not a from and through. So if you think about something that may happen in a revenue center line, you'll get a single date, even though we may know that the service actually spanned a number of days. So that's where the claim from and claim through on the base file and the date of service date on the revenue center file, sometimes we sort of have to put them together to try to understand when something happened. So there's also revenues line payment. So in addition to having an overall claim payment and a claim denial code, for each line, there will be a revenue center payment amount and a patient responsibility for that exact line. So we can both see it summarized at the claim and line by line. So when you're linking, and just to sort of comment there, so it's completely possible that what you'll see is an approved claim with denied lines. So you could imagine an outpatient claim that may have 4 revenue centers. There might be circumstances where one of those revenue centers would be denied and 3 would be paid. The overall claim would look like it's paid, but when you actually look line by line, you may see some services were in fact not covered. So it's more of an issue with the Carrier file, but you see the same pattern here in the outpatient. So when you link the claim to the revenue center, because again, what you really want to do now is put the when, where, why next to the what. What you need to do is you need to put the base and the revenue center together, knowing, of course, that there will be multiple revenue center codes for a single line. So again, we've got this one-to-many link. And that link and handling it properly is very important to everything related to using claims, and not just in the outpatient file. It's an issue that we face with the carrier file, inpatient file. It's why the MedPAR is such a service to all of us, although we may complain on occasion, because they do it for us. So in order to do this, you need to link two, you need to use two variables, the Benny ID, which is a particular beneficiary, and the claim ID. And with those two pieces of information, which are on the base segment and on the revenue center lines, you'll be able to reconstruct the claim. So that is how you need to do it, but you need to use both fields. Claim ID alone won't do it. That doesn't often, but that can repeat across beneficiaries. Multiple beneficiaries can share a claim ID. The claim ID is not unique unless it's combined with a Benny ID. And then remember that the claim IDs can also repeat across years. So it's very important when you do these links, you do them 1 year at a time, because you could, again, it's just a random identifier. You could get the same claim ID for the same person across a couple of years. It's not common, but it can happen. And when these things happen, they take a ridiculous amount of time to sort out. So just to think about it, imagine we have somebody with two claims. We have Benny ID A, which again is too short, and they have two claims. They have claim ID 123 and they have claim ID 456. Total payment for claim A, for the claim 123 is $612. The total payment for claim 456 is $350. The principal diagnosis for 123 is a broken arm. The principal diagnosis for the second one is a screening mammogram. Excuse me. We also can look at the revenue center codes, as we expect with every claim. We have a revenue center code of 00101. It's the revenue payment is 0 because there is no revenue, but it's a summary. The claim payment amount is going to add up, and we're going to see it. And we're going to see one is for the emergency room and the other one is for a lab. And the 412 revenue payment and 200 revenue payment will add up to the 612. So that is how these roll up. So these are examples of what a base would look like. And even something simple like a mammogram will have two records. It will have a 0001 revenue center code, and then another. It probably shouldn't be OB-GYN, it should be radiology, but you get the point. So then when you put this all together, this is what you would do. You would take the Benny ID, the common fields across both, the Benny ID and the claim ID. There would be a total payment amount. So now you see for claim ID 123, we now have one record. We have 3 records, and for 456, we have 2 records. And we have same repeats on principal diagnosis and claim from date. But the trailers, we get different information on which revenue centers, which HCPCS, and revenue payment amount. So then what we would want to do is to then collapse those and string them out long so we could turn it into a single record. Or we would decide the total payment is what we care about. But the point of it is this is how you put it together. Now you notice this still has got repeats by person, and you might, as I typically like to, get down to 1 record per event or even 1 record per person. And this is, again, what Sammy's going to talk about later on today, which is this idea that you've got to do multiple steps and multiple collapsing to get what you want and to make sure you don't lose information or mislabel information. So when we're using the outpatient file, just a reminder that, that the base claim trailer can be used alone to identify diagnoses, dates of care, and payments. The trailer alone can be used to identify procedures, dates of procedures, and payments for procedures. But really, to do what we almost always want to do, you're going to need to put the two together so you can have diagnoses and procedures and to identify the facility in which a procedure was performed. So I know of no way around that. So now moving on to the carrier file. The carrier file is simpler, and it's a base plus a line file. It used to be called header and trailer. So if I slip into that, I apologize, but it's the same structure. There's a base, and then there are these lines, and the lines repeat. You can have multiple lines per base. The base claim file has information about, it has the BENI ID, it has the demographics, it has place of residence information. It has information about the claim, it has claim from date, claim through date, claim payment amount, and it has up to 8 diagnosis codes, or now 12 diagnosis codes. And don't forget, again, XX000 is a laboratory test diagnosis, so that if you see that, it's not an unknown diagnosis code. It is, in fact, exactly what policy says it should be. There's also a line file. Each claim can have up to 13 lines. So that means that if somebody has 17 lines, they will have 2 claims. They'll be broken up. The line diagnosis code has to be one of the summary diagnosis codes, but it can be any one of them. So in the header, if you remember, in the base, we have 12 diagnosis codes. Every line has to have a code that is one of those 12. So what it means is you don't need to go through and say, well, let me check the lines to make sure there aren't other diagnosis codes I didn't know about. The answer is, again, by policy, it is, you don't have to worry about that. When you're trying to line up carrier claims with inpatient or outpatient claims, the dates of service are very useful, and the place of service codes are very useful. Where did the care occur, which might help you figure out if there's likely to be a facility claim, and the dates of service will help you figure out if it overlaps. And as we talked about a little bit ago, if you want to calculate the total amount with full details, you're going to have to put this together. But the other piece is, as you remember, we've talked about, for example, with x-rays, there'd be the charge of the x-ray equipment and the charge for the radiologist interpreting the x-ray. The CPT code for both those things is the same. So we want to make sure we don't double count. So to say, well, was this 2 x-rays or was it 1 x-ray billed in 2 components? And then in some cases, it will allow us to get more information. So for example, if you're looking at inpatient care, the ICD procedure codes and the CPT procedure codes have different information. So sometimes by combining them, we can understand more than we would with either one alone. Line place of service codes, office, home, inpatient hospital, outpatient hospital, and so on. You have to be aware that there sometimes is some slippage. So for example, I've seen inpatient hospital and outpatient hospital for anesthesiologists get mixed up because, again, they're the same operating room, and the anesthesiologist may or may not exactly know what the patient's status at the end of the day is going to be. They may know what the plan is, but it doesn't affect their billing. So sometimes you will see miscoding there. You'll know it happened in a hospital, but the inpatient versus outpatient for that role may not be correct. For other roles, it may be, and that's the other thing we have to be patient with. Is in some cases it will matter, in other cases it won't. But these are examples of the place of service codes. HCPCS in the carrier file have modifiers, and a modifier is something that helps us interpret what was going on that might affect level or payment. So for example, I'm going to start with the bottom one. There's laterality, left and right. So we have 2 eyes, so we can have 2 cataract surgeries. We can have 2 hips. You think about all of our paired body parts. CMS does not want to pay for the same thing twice. So if you bill for a cataract excision and then 6 weeks later you bill for a cataract excision, if you don't document laterality, they're going to be, we just paid for this 6 weeks ago. So you have to document and say, use the modifier LT for the first one. We did the left eye 6 weeks later, we did the right one, or we did both at the same time, and we're going to document that. So when there's laterality and there can be legitimate repeats on both sides, this is often used. Likewise, there's what's called a technical component, and that would be a way of saying, this is the amount that we're paying for the facility side of things. So if there's a risk that is going to be rejected or adjusted because it's not clear whether it's a facility or facility plus provider combined, they will specify that. 26 means professional component. That means I'm charging as a provider, as a physician, or as a nurse, advanced nurse practitioner. Technical component would be we're charging as the person, as the owner of the machine, if you will. There also are other examples like 21, which means prolonged evaluation and management. So not only was this a complex new patient, but this was one that took a really long time. And so we're going to put the 21 in to say we need an extra bump in the payment because it took so much longer than what we would typically expect for a complex new patient. Money. The money is different in the carrier file. The line allowed charges are the amount CMS will pay. So it isn't, so if you think about, we said yesterday that in the hospital files, hospitals can charge whatever they want and CMS pays whatever they will pay. Well, in the carrier file, hospitals are only allowed to charge what CMS says they are willing to pay. And then the payment amount is the amount CMS pays, taking into account co-pays, deductibles, primary payer amount, and so on. So money is a little bit different here. So just be aware of how to interpret the charges because it's not quite the same. The other piece with physician payments is, well, there's no bundling or prospective payments. They do change what they pay. So for example, if for a physician who does a colonoscopy, if they're doing it in a facility, they, for example, would get paid a different amount. So the non-facility amount for a colonoscopy with biopsy is $399, but at a facility, the physician themselves is paid $180.92. So you will see this. So if you're looking, for example, at colonoscopies or at things that can either be done in an ambulatory care center or in a facility, you're trying to figure out how much somebody is getting paid or where the incentives are, do take into account that there will be different location payments, and these are new. So if you're looking at changes over time, or you want to understand how these new facility payments affected how people do practice care, this is a place you would look to understand it. So again, earlier today, we had a question about denials. Carrier claims can be denied. So a claim denial code will indicate the entire claim was denied. Claim payment will be 0. And again, about 6 to 10% of claims are denied. Most commonly, I believe, is because somebody got a little impatient and hit send twice. But there are other reasons as well. For example, if a claim is submitted and the person isn't yet enrolled in Medicare, it will be denied. If somebody hasn't paid their Part B premiums, it will be denied. So there are reasons why things are denied beyond just hitting enter twice. There's also a line processing code, and that is to say, as we saw with the outpatient, line by line, we could deny things. So an A means it's allowed, which means we're paying it. Anything else is a denial code. Interestingly, almost 10% of claims have at least one line item denied. So, and most commonly, it's when things are bundled together in terms of payment, and then they're split apart in terms of billing. And so, if they're denied, the allowed amount will be 0. And we will see other things. And often, again, what it would be, for example, most surgeries include routine pre-op and routine post-op. But every once in a while, you'll see a surgeon who will bill for pre-op and bill for post-op. So they will put 3 lines in, when the assumption is the surgical payment includes the routine care, and then the pre-op and routine post-op by that provider would be denied. Carrier claims also have what are called MTUS codes, and MTUS codes are incredibly valuable and incredibly helpful, and they stand for miles time unit services. And what this is this tells us what are the units that this is billing in and how many are there. So the indicator will tell us, for example, when there's a count of how many, it will tell us what it is. Is it anesthesia units? Is it miles for or is it services? So we'll see mostly 3. So if it's a E&M visit, a doctor's visit, the units, the code would be a 3, it's services, and the units might be 1. They had 1 evaluation and management visit, or they had the code would be a 1 transportation, and the units would be 40. They had a 40-mile ambulance ride. So that's how it works. So these can be useful to understand how much somebody is. They're the multiplier. In the carrier file, there are provider, let me just, before I keep going, let's just check the, so the question, just to go way back, actually, let me do, Chris, remind me, I'm going to do yours at the end. It's an important thing. Rule out diagnoses. We'll talk about that at the end. Actually, let's do, I'm seeing, I don't, Steph, do you see anything that we need to answer right away? I'm going to keep going.
I don't think so.
We should have time at the end to do, I think there's a bunch that I think will work best then, don't you?
Yeah, I don't think any of these are specifically clarifying just right now. So yeah, a lot of them I think will be good to address at the end.
Okay, perfect. Provider information. There's a provider specialty code. There's a line performing NPI, and there's a line tax number. So the tax number really will be often shared across people. This is like the tax ID for a physician practice. So it's one people will sometimes use it to identify providers who are in the same physician practice. The specialty codes, general practice, general surgery, allergy, otolaryngology, anesthesiology, and so on. These are not the same as board certification. In some cases, people who are board certified in something may keep a specialty code that's more general because it lets them do something. So I have a friend who's a specialty surgeon, a colon surgeon, colorectal surgeon, who keeps their code as general surgery, even though they could do specialty surgery. And the explanation I got is that they like to install, because often they have to, their patients will need chemotherapy ports. And if they were listed as a colorectal surgeon, they wouldn't be allowed to put in ports because it makes no sense for a colorectal surgeon to do it. It's a general surgeon, but they like to do it as sort of a service to their clients. So that would be an example. I don't know if, and I haven't confirmed that that actually makes sense or is right, but that is definitely something that people have said. So those are possible things. I have never checked, for example, to see whether family practice, internal medicine are distinct or whether they matter or how accurate it is. There are ways to do that linkage and to link with board certification if you're interested. And if you want to go down that road, I would just encourage you to call ResDAC and we can help you through it. Again, lots of line specialty codes. Some of them are far more specific than they need to be, like a lot of stuff. It doesn't, you don't have to use all special, you don't have to use the most precise thing that's available. So often what it means, which gets frustrating as a researcher, is there seems to be more of a promise than is sometimes delivered. And we find that people are often classified very generally, even when it would be possible to classify them more specifically. So thinking about your own research now, which files do you think you're most likely to use? I'm going to give it just a couple more seconds and we'll close out this poll. Okay, so just for everybody, this is a typical pattern, and I think it actually aligns really consistently with my own research in terms of, if I think about it in terms of studies or percentage of studies. And that is to say, the vast majority of time, I use both files. But there certainly are many times when I've decided to use the outpatient file only and have been able to say, I can do this and I don't need the information from the carrier file. There are fewer places where I would say I only need the carrier file. For what I'm trying to do, I feel it can be complete with carrier alone. And every once in a while, but not that often, I decide that I really don't need either file. I can get by with an inpatient or hospice or something else. So this is a really, the way you all have reported is exactly what I have done in my career in terms of using the combinations of outpatient, carrier, both, and neither. So deciding how to use a carrier file. This is one of the tricky parts about the carrier. The carrier, the question is because, as we said, it gets very large very quickly, and the size can make it challenging to work with. And even though it says, well, it's a computer thing, the reality is even the fastest system, it takes time to run things. And so the runtime with the carrier can be a problem. And I'll be honest, with ResDAC, even with all of our computing resources that we have, we find that we've had to do things to make use of the carrier file more nimble. So CMS offers what's called a 5% sample. The 5% sample is a random sample based on the random identification of Social Security numbers, and it's been in use, the same random sample, since the early 90s. So you don't need to worry that if you order a random sample in 2020, that it will be somehow different than the random sample you got in 2023. And if you want to link the two random samples, you just tell CMS that. So one of the advantages of the 5% is 5% of 60 million is a really nice number, and it's a lot of people. And we don't always need more than that if we really want to go with a population base. So this is an advantage. We could go with a smaller percentage. You cannot receive a national carrier file other than 100% other than through the VRDC, which is, remember, the online enclave we talked about. But even then, you have to have a reason to need access to it. So part of HIPAA says minimum data necessary. And so if you say, I need 100% of the carrier file and I need access to the entire file, you're going to get pushback. And they're going to say, well, do you really need 100%? Or do you need 100% of something? So that is to say, it's hard, you can't necessarily, and you certainly can't easily get 100% of everything, but I can say, well, no, I just need 100% of people with injury diagnoses. Here are the diagnoses I care about, and I need 100% of the records for people with these diagnosis codes. That you can get, and that is easier to get and often much more appropriate than saying, I just want everything and I'll take care of it. So you really need to carefully consider whether you really need 100% of your population, and think about how long the processing time is going to take. So coding is not a problem, it's processing time. And so consider, do you really need, and if you're going to have multiple years, again, these sort of exponentially grow. But consider diabetes. Diabetes has a 20% prevalence. So do you really need 11 million people to answer your question about diabetes care? You might need to use the base of it, but even for some of these sort of prevalent conditions, you do want to ask yourself, is this in fact scientifically necessary, or am I just sort of being a data hoarder? Been accused of that a few times. And I want everything because then I can make the decision. So you will get pushback from CMS on that. And I will just say practically, and I'm guessing Sammy will repeat it, that really, do we need this level of precision, or are we in fact going to find ourselves doing things that actually makes it so we get rid of most of these people anyway, because it's the only way we can get our work done. So summarizing the differences between the outpatient and the carrier files, they use different claim forms. The carrier uses a CMS 1500. The outpatient uses the UB04. The carrier is for non-institutional providers, primarily physicians, but also freestanding ambulatory care centers. The outpatient is for institutional providers who also build Part A, so primarily hospital outpatient departments. They both use the same diagnosis coding, ICD-9 and ICD-10, depending on the year. Carrier is exclusively CPT/HCPCS coding. The outpatient uses CPT plus revenue center codes. So the CPT codes are within a revenue center. The structures, carrier is base plus line, outpatient is base plus revenue center, so very similar structure. There is no summary record for the carrier, but there is one for the outpatient. So when you're cleaning out those summary records or keeping them, that's what you're going to do. But this is where the carrier starts to explode on us. The median number of claims per person per year in the carrier file is 16 compared to 4 in the outpatient. So you can see why those files are so much bigger. Though I actually find it quite interesting that the median number of lines per claim in the carrier file is 1 compared to 3 in the outpatient. But do remember the 3 in that median does include the base file. So but at least slightly, when there is a record in the outpatient, there's going to be more going on than when there is in the carrier, but there can be many, many more records in the carrier. So that is the difference between the two, sort of in a nutshell as you're thinking about them. So my final thoughts are they're both necessary for almost all studies of outpatient, meaning non-inpatient care. They both have one-to-many structures, so you're going to have to be able to get your head around that and figure out how to manage it. It really isn't that much harder to use the 2 files versus the 1. And that's why I told you that most of what I've done when I go into this space ends up using both with some very specific exceptions. And it's mostly because when you're writing that strengths and limitations section of your study, it's harder to say, well, I'm making this assumption, and because of this assumption, I'm going to rely on an assumption rather than actually use the data. I've had times when I've had to, but when I can avoid it, I try to. And again, as I said, please stop and take the time about how you expect this to be present between the 2 files. Do I expect more of this care to be in the carrier, more in the outpatient, an equal mix? In part, it will allow you to problem solve and to think about your data and whether your results make sense. And it's a whole lot easier to do that at the early stage than to have a reviewer come back and say, I'm not sure I think your numbers are right. I think this. So again, because these are complex, but because there are increasing numbers of people who are experienced using these, I've certainly more and more had people coming back saying, I'm not sure that I agree with your assumption. Can you please justify it? And both take time and it takes time. So both of them, to line up the variables between the 2 files, to pick what you need, consider how you will use it, and decide whether, in fact, these are apples to apples across the 2. But these are just time-consuming files, and there is no single answer for how you're going to handle them. So with that, at the end of this segment is some source of information manuals. I do encourage you, I'm not sure we've said this before, the claims processing manuals are incredibly useful. They will often explain how people are told to do things. So when you're trying to understand, because again, our goal is to figure out what a provider would do so that we can find it. And the claims processing manuals are the place where I would encourage you to go. I've learned and found amazing things there. And when ResDAC gets a call about something new, the first thing we do is we go to the claims processing manual to see if that provides any insight. The second thing we do is go to the data to see if it lines up. Here's some more manuals. You've got these. And so with that, I think we've got some questions to go to.
Yeah, I can maybe help that with there was one kind of way back about identifying rule out diagnoses. What are your recommendations for that?
So I think the general algorithm advice that is used, and Nate will talk about it, is sort of 2 on 2 different days from an outpatient, in an outpatient or carrier. Some people do an extra saying face to face. We sometimes have to do things. If you want to just sort of think about it, what I'll often say is, what would it look like? So when we, for example, we see somebody who is, I'm just trying to stop screen sharing. Did I do that correctly?
You did.
So when we do something and we say, okay, do I really believe that somebody who legitimately has prostate cancer would only have one newly diagnosed, no sign of it before, that they would only have just one claim? And I think the answer is no, I don't believe that. I don't think that is right, and I don't think it could be right. So that's some of what we do, but often it's the two claims from this source. Other questions?
And sorry, I don't know if you had identified any questions you wanted to answer.
No, I was just pulling it up. It's sort of my screen started going crazy for a minute.
Yeah, there are some questions about linking between data sets, like whether or not some of the linking variables apply to HRS linked CMS data, or when you can link and when you can't link. I think maybe when we go through the exercise, you can kind of see what the linking variables are. I don't know if you have anything else you want to say about that.
My other comment is that to link, you have to plan to link. And that means when you're requesting your data and you plan on linking it to an external source, if in the request process, it will say, what do you plan to link to? I plan to link this by zip code. I plan to link it to an external source, in which case the next question will be, well, what information will you have? And there are things, and we can talk about it later this afternoon, called crosswalk files. So if I have Medicare Benny IDs, right, it's the ones that are on the cards, and I want to link it to claims, what I would do is I would tell CMS that, and then there would be a process where we would create a crosswalk file where my identifiers would be crosswalked to the Benny ID that we get in the claims files, and then that would be used. So the idea is that you can link in just about everything from the Medicare side. If you get files through that you order through ResDAC, it will be linkable through the Benny ID. But even there, because of how, if you remember from yesterday, how the Benny ID is created, you have to tell CMS and you have to tell the data distributor, the CCW, what your plan is, so that they can make sure they use the same Benny IDs for the files you're planning on putting together.
Thank you.
Fraudulent billings. How can you identify fraudulent billings? Fraudulent billings will usually be an algorithm, is how I understand. So it's like, okay, this doesn't make sense. This is either this one provider is doing way too much, or they get out of sync with other things. Like, wait a minute, you cannot be in two hospitals at the same time. One of them must be fraudulent. I think definitively knowing fraudulent billings from claims alone can be hard, but that often what will be done is they will use claims to identify things that are likely to be fraudulent or likely to be problematic. How much are the code books? The code books are actually ridiculously expensive, which is why we ended up getting them on eBay, because I was shocked at how much new code books are, but they're super useful. So if you get NIH, you should be able to charge for the coding, but they are amazingly expensive. Let's see, what other questions, Steph?
Someone was asking about incident to billing. With like a nurse practitioner that would bill incident to a physician services, and whether or not we can identify that in the claims.
So the way you would identify that would be through a modifier. So what should happen is both the nurse practitioner and the physician would put modifiers. It'd put sort of equal and opposite modifiers, if you will. So the nurse practitioner would code incident to a physician, and the physician would code incident to a nurse practitioner. The other places where we see that is, for example, if there are two surgeons working on a case, they will use modifiers to indicate, no, I was the second surgeon, or I was the assisting surgeon, or I was whatever. So it's the same idea. We also see it with anesthesiology, where there'd be a supervising anesthesiologist and a nurse anesthetist, excuse me. So those are other places. And those are also, again, where the modifiers can be really helpful, because you can see it, and then you can see that the payments that they get would depend on that role. What is the purpose of the summary line? I don't know. I mean, I tend not to use it. I think for some people it makes it easier. For me, I'm just ticky and probably, Sammy or Steph may have a better idea. I tend to think that the best thing it can do is it allows a check, so that if I get different answers than the summary line, it's a sign that I did something else. And I am a very rusty coder. So if you're not as experienced with a coder, if you're getting answers that aren't making sense, it can be super useful then, where we're like, okay, and often that's what we'd do, is we'd use it as a cross check rather than as a substitute. Facility versus non-facility. Is this because technical fees are paid separately, or is it because the physician gets paid to do more things in this? It's because for some of these things, there are two parts to it. And for the procedure itself to be complete, you need both. You need a physician to do their role, but you also need technical equipment, and you need to recover the costs of that. And so again, x-rays are my personal favorite because they're the clearest, or anything where you need, so if you think about x-rays, you need the x-ray machine, you need the tech. So not the radiologist who's interpreting, but you need an x-ray tech, you need the staff, and those things cost money, but you also need a physician interpreting it. And it can be done by a facility and a physician working separately, or it can be done by the two working together. And so what happens is this is just a way that allows it to be billed either way, so that if the hospital is billing for the radiologist, they would indicate that, and their payment would be larger than if the radiologist was billing separately. So that's what it means by facility and non-facility. But typically, if it's broken up, the radiologist billing separately, the radiologist would show up in the carrier file, and the facility charges, if they were in a facility that provides Part A care, it would show up in the outpatient, and if it was a freestanding institution, they would show up in the Part B. E&M codes, evaluation and management codes are part of the CPT codes, and they're quite detailed, but what they do is they're basically an office visit. So evaluation and management. So they're a way to bill. It's not exactly a procedure in the sense that it's not a surgical procedure, but the amount of effort they take and what they take will depend quite a bit on why they are doing it, how complex the patient is, what the setting is, whether this is a new patient or an established patient. So that's what the E&M codes are. And there's something that I've gained more appreciation for as I've gotten more experienced in sort of moving into different types of questions. So they may or may not matter depending on what you do, but they're definitely an example of codes that you do. And then the question is, do well visits have certain codes? And if you remember, and I don't have it memorized, there is the Welcome to Medicare code, there's the annual visits, and those all have G codes. So those are specific policy visits. But in general, there's also a coding convention that says that if you do a well visit and you find something wrong, you will convert to a sick visit. As a parent, when my kids were small, that used to drive me crazy. I'd go in for my well child visits with my kids, which has no copay, and they would find an ear infection, and then I'd have to pay a copay. And I remember just wanting to say, just pretend you don't see it, please, because the rules about copays and everything else are shifting. But again, well visits will certainly, I would look in the G codes in particular because of sort of the policy linked to encouraging primary and preventive care.